Hello, everyone. Today I'll be talking about novel immunotherapies for myasthenia gravis. So, myasthenia gravis is the prototype of an antibody-mediated disease, and the pathogenic antibody is directed against the postsynaptic acetylcholine receptor, which is present in 85% of the cases in generalized myasthenia gravis, which have 6% against muscle-specific kinase, and 1 to 2% have a low-density lipoprotein receptor-related protein 4, the LRP4. A breakdown of immunotolerance by an unknown trigger sets in motion the CD4 T cell upregulation, which drives the pathogenesis of this disease. The CD4 T cell mediated upregulation of pro-inflammatory cytokines leads to a proliferation and differentiation of B cells to an antibody secreting plasma cells, memory B cells, and long-lived plasma cells. The antibodies in acetylcholine receptor positive myasthenia gravis are subclass IgG1 and IgG3, and they bind with the postsynaptic acetylcholine receptor, leading to a complement cascade formation of membrane attack complex, which leads to the reduced end-placed potentials and failure of action potential transmission. The pathogenesis in MuSK myasthenia gravis differs in that the antibodies belong to the IgG4 subclass and do not activate the complement pathway, but act by masking the site of the normal MuSK LRP4 interaction and thus prevent the acetylcholine receptor clustering. So the acetylcholine receptor positive myasthenia gravis are classified into three subtypes: the early onset, which is less than 50 years of age, the late onset, more than 50 years, and the thymoma associated myasthenia gravis. Early onset myasthenia gravis has a female preponderance and strong associations with HLA-DR3-D8 and thymic follicular hyperplasia. In contrast, the late onset myasthenia gravis often occurs in males and has no HLA association and may display as anti-striatal antibodies despite harboring an atrophic thymus. Thymoma occurs in 15 to 30% of myasthenia gravis and is commonly associated with a coexisting anti-ryanodine receptor and anti-titin antibodies. MuSK myasthenia gravis tends to present with the bulbar predominant phenotype and usually do not have any significant thymic abnormalities. So the pathological changes in the thymus are believed to play a pivotal role in the pathogenesis of acetylcholine receptor myasthenia gravis. The most accepted hypothesis centers around the failure of self-tolerance, which occurs in the thymus in acetylcholine receptor myasthenia gravis. A balance between immune cell generation and timely removal of autoreactive lymphocytes ensures self-tolerance. The thymus is a primary organ for the maturation and differentiation of T cells. During their maturation, the T cells, including the T regulatory cells, are exposed to the thymic myeloid cells, which express the acetylcholine receptor, and the autoimmune regulatory medullary epithelial cells, which play a role in the clonal deletion of the T cells sensitized to autoantigens during the development of central tolerance. The lymphocytes which display the autoreactivity are removed within the thymus, whereas those that escape the sculling are suppressed in the periphery by the T regulator cells. So the two important factors which contribute to the immune breakdown in myasthenia gravis are thymic pathology and genetics. In early onset myasthenia gravis, the thymus shows structural changes in the form of thymic follicular hyperplasia. The germinal centers of the follicles are implicated as the site of origin of autoimmunity in them. The mechanism includes either the aberrant production of cytokines or an imbalance in the function of T effectors and T regulatory cells. So there's an increase in the pro-inflammatory Th17 and T follicular helper cells, which promote the B cell activation and generation of the autoantibodies. The regulatory B cells which suppress the autoimmunity are functionally abnormal. In thymoma-associated myasthenia gravis, the pathological abnormalities consistent with immune proliferation in the areas adjacent to the tumor have been reported without any follicular hyperplasia. The thymomas express a loss of autoimmune regulatory epithelial cells, making the cells susceptible for mounting an autoimmune response. The late onset myasthenia gravis is associated with an involuted thymus with paucity of myeloid cells and regulatory thymic cells which prevent the autoimmunity. No specific thymic pathology has been demonstrated in MuSK myasthenia gravis. Coming to the clustering and dispersion of acetylcholine receptors on the muscle end potential, where the agrin binds to the LRP4, and this complex helps in the activation of MuSK. And Musk further through the DOC7 helps in the anchoring of acetylcholine receptor and clustering of these receptors on the end plate through stabilization by a rapsin. Whereas acetylcholine in itself causes a dispersion of the acetylcholine receptor through calpain and CDK5 mediated activation. So the agrin binds to the LRB4, resulting in Musk activation and recruitment of DOC7 and CRK ligand, which further stimulates the Musk activation. The signal is propagated downstream, which results in the clustering of the acetylcholine receptors by the cytoplasmic anchoring protein rapsin. Whereas the acetylcholine disperses the acetylcholine receptor clusters, which are not stabilized by this agrin signaling. The calpain promotes the cleavage of P35 to P25, which activates the CDK5. And this CDK5 is responsible for dispersion of the acetylcholine receptors. So the rapsin behaves as a calpain suppressor, thus stabilizing these acetylcholine receptor clusters. The pathogenesis at the end plate, which causes the the myasthenia gravis, includes the complement-mediated lysis of the end plate potential, or the cross-linkage and internalization of the acetylcholine receptors, or the blocking of the acetylcholine blocking site, binding sites on these acetylcholine receptors. The conventional immunomodulation, which has been approved in myasthenia gravis, includes the corticosteroids, azathioprine, mycophenolate mofetil, cyclosporin, tacrolimus, methotrexate, cyclophosphamide, IVIG, subcutaneous IVIG, and the plasma exchange. However, newer modalities have been approved and novel mechanisms have been discovered and new drugs have been formulated for myasthenia gravis, which include the complement inhibitors, the FcRn inhibitors, the cytokines and chemokine associated medications, the B cell inhibitors, and the plasma cell inhibitors. So the normal agents which included in the complement inhibitors, C5 inhibitors, include the eculizumab, the zilucoplan, and ravulizumab. The FcRn inhibitors includes the efgartigimod, the rozanolixizumab, nipocalimab, batoclimab. The B cell inhibitors include the rituximab, inebilizumab, satralizumab, mezagitamab, and the T cell inhibitors includes the CAR T cell therapy and finally the hematopoietic stem cell transplantation. So coming to each of them, coming to first the complement inhibitors, the autoantibodies in myasthenia gravis, specifically the acetylcholine receptor antibodies, which are IgG1 and IgG3 mediated, they act through the complement, activate the complement system through the classical pathway and cause the generation of membrane attack complexes, which damage the end plate. So the inciting antibody binds to the C1q complement protein, which sets off a cascade leading to activation of the C3 convertase. This C3 convertase activates the C3 to form C3b, which forms the C5 convertase. And the C5 convertase converts the C5 to C5a and C5b. The C5b further joins the C6, C7, C8, and C9 to form a membrane attack complex. And this membrane attack complex leads to the lysis of the postsynaptic membrane and plays an important role in the pathogenesis of acetylcholine receptor mediated myasthenia gravis. So eculizumab is a humanized monoclonal antibody directed against the C5 complement protein. So the binding of eculizumab to C5 prevents its cleavage to C5a and C5b, further preventing the C5a induced chemotaxis of inflammatory cells and also the formation of membrane attack complex by the C5b. It was previously licensed for paroxysmal nocturnal hemoglobinuria and atypical hemolytic uremic syndrome. It was approved for therapy of generalized myasthenia gravis in 2019. The product carries a boxed warning on the risk of meningococcal infection. Subjects for the clinical trials were included after mandatory vaccination against the Neisseria meningitis at least 2 weeks prior to the first infusion.
The others less serious side effects include headache and nasopharyngitis. So the phase 3 placebo-controlled randomized regain study enrolled 125 acetylcholine receptor antibody positive refractory generalized myasthenia who were assigned to either eculizumab or the placebo group. The induction dose of eculizumab was 900 mg on day 1, weeks 1, 2, and 3, and 1200 mg in week 4, and thereafter a maintenance of 1200 mg every second week for 26 weeks. The primary endpoint assigned was the change in myasthenia gravis activity of daily living scores from the baseline to the week 26 using the worst rank ANCOVA, and the secondary endpoints assessed were the change from the baseline in the total scores of quantitative myasthenia gravis score, the myasthenia gravis composite, and the myasthenia gravis quality of life 15, and the proportions of the responders. The study failed to attain the significance of the primary endpoint. However, the secondary outcomes were significantly better in the intervention group, including the changes in the QMG and the MG quality of life 15 scores and the responder analysis for MG, ADL, and QMG. A major drawback detected in the trial design and the possible reason for the negative result for the primary endpoint was the use of the worst rank analysis. This was notable in the eculizumab group, where 3 patients who had good therapeutic responses discontinued due to side effects other than the myasthenic worsening, namely the Moraxella lacunata bacteremia, bowel perforation, and prostatic carcinoma. In post hoc analysis, 25% of the refractory myasthenia gravis on eculizumab had retained minimal manifestation status at 26 weeks, which was double of that of the placebo group. The participants of the regain trial were enrolled into an open label extension phase for a maximum of 4 years. After a blinded induction phase, that is, the active drug provided as 1200 mg every 2 weeks for eculizumab group and 900 mg on day 1 and weekly for 3 weeks for the previous placebo group. All these patients were continued on 1200 mg once in 2 weeks. A total of 117 participants, 56 in the previous eculizumab and now eculizumab group, and 61 in the previous placebo and now eculizumab group entered the study. The primary endpoint was a change in mean myasthenia gravis ADL score over time. Interim analysis showed a reduction of 75% in the episodes of myasthenic worsening compared with the baseline. Infections of specific interest occurred in less than 1/5 of the study group, and none had meningococcal meningitis. Improvements in myasthenia scores and quality of life scores were sustained with rapid improvements in the placebos with the eculizumab group. In the regain trial, the eculizumab treated patients were 2 times more likely to have achieved the minimal manifestation post-intervention status compared with the placebo at week 26. While in the OLE study at 130 weeks, a substantial majority, 88% of the patients had attained improved status and 57.3% had reached minimal manifestation status. The minimal symptom expression defined as MG-ADL score of 0 to 1 or MG quality of life 15 score 0 to 3 was attained by a significantly higher proportion of eculizumab treated patients at week 26 of the regain trial. The RCT and the OLE various subgroup studies and case reports have firmly established the role of eculizumab as a rescue therapy in resistant myasthenia gravis, but its role as a first-line agent and duration of therapy are undefined. The annual cost of therapy, which exceeds $500,000 has been a major deterrent to the wider use of this drug. The second drug, the ravulizumab, is a long-acting C5 complement inhibitor and has a mechanism of action similar to that of eculizumab. The long half-life of this molecule necessitates pure intravenous infusions for maintenance. This drug was previously approved for PNH and is under investigation for atypical HUS and IgA nephropathy. It has been licensed by the regulatory authorities for generalized myasthenia gravis in 2022. So the terminal complement inhibitor ravulizumab in generalized myasthenia gravis. In one of the phase 3 randomized placebo-controlled, the champion myasthenia gravis study, 175 adults with symptomatic acetylcholine receptor antibody positive generalized myasthenia gravis were recruited to receive ravulizumab infusion versus a placebo. The participants were randomized to 1:1 to the treatment and control arms. The dosage of ravulizumab was weight-based, given as 2400 to 3000 mg single loading dose on day 1, followed by a maintenance of 3000 to 3600 mg every 8 weeks, starting from day 15. The primary efficacy endpoint of significant improvement in the myasthenia gravis ADL and for the secondary outcomes were achieved in the treatment groups at 26 weeks. No marked difference in the adverse effects were noted between the two groups. The open label extension phase of the study is still ongoing. The zilucoplan is a small macrocyclic peptide molecule which prevents the terminal activation of the complement cascade by two mechanisms. It binds to the C5 complement component and prevents its cleavage. It additionally binds to the existing C5b to prevent its attachment to C6, which leads finally to activation of membrane attack complex. The molecule is given as a subcutaneous injection. The advantages of this molecule includes a small size, which ensures good NMJ penetration, ability to concomitantly administer IVIG therapy as this is not an antibody, and the potential for self-administration. The phase 2 clinical study in symptomatic adult acetylcholine receptor myasthenia gravis patients, 44 patients were randomized and received one of the three interventions. Once daily subcutaneous injection of zilucoplan at 0.3 mg per kg, once daily zilucoplan at 0.1 mg per kg, or placebo. The main efficacy points of changes in myasthenia gravis ADL and QMG scores were assessed at the end of 12 weeks of treatment. High-dose zilucoplan group showed a rapid and statistically significant improvement in the scores compared to the placebo. They also had reduced need for the rescue therapy. No serious treatment adverse reactions were reported with zilucoplan. The phase 3 trial study the efficacy trial to study the efficacy and tolerability of 0.3 mg per kg zilucoplan versus placebo has been completed, and it has been approved for generalized myasthenia gravis this year by the FDA. The RAISE trial was the study which assessed the efficacy of zilucoplan in the generalized myasthenia gravis. So the next inhibitors are the FcRn inhibitors. The immunoglobulins are heterodimers. They are made of two heavy chains and two light chains. Each immunoglobulin molecule has a variable region which houses the antigen binding fragment and a constant region with the complement binding crystallizable fragment. The attachment of the Fc fragments to the Fc receptors is crucial in regulating their interaction with the cellular immune mechanisms and enhancing the serum levels of IgG. The latter function is modulated by the neonatal Fc receptors widely distributed in multiple cell types, particularly the endothelial and the myeloid cells. The FcRn helps in recycling of the IgG and increases its longevity in the circulation. The binding of the FcRn to IgG is pH dependent and occurs only in an acidic pH. After the uptake of the IgG by the cells, it is transported to the acidic environment of the endosomes, where the FcRn binds to the IgG and protects it from the degradation by the lysosomal enzymes. The FcRn transports the IgG back to the surface and it releases it into the neutral physiological pH. This pH-dependent binding is essential for prolonging the half-life of the IgG antibodies, which typically remain in circulation nearly 4 times longer than any other immunoglobulin subtypes. So at physiological pH, the IgG remains in the circulation. It is taken in through an endocytic vesicle, and it is bound to the FcRn, which prevents its degradation by the lysozyme. And it then recirculates this immunoglobulin IgG at the physiological pH out back into the circulation. So if this FcRn is blocked, the IgG, the immunoglobulin, can be degraded by the lysozyme, and it reduces the antibodies in the circulation. So the drug which has been approved is the FGARTI-Gmod. It is an engineered Fc domain of the human IgG1 with an increased affinity for FcRn inhibitors than the endogenous immuno-IgG, thereby competitively inhibiting the IgG's recycling. So the ADAPT trial is a phase 3 multicentric randomized control trial which proved the efficacy of efgartigimod against a placebo. The study included adults with generalized myasthenia gravis, irrespective of the antibody status, on a stable dose of anti-myasthenic medicines and an MG-ADL score of more than equal to 5. The efgartigimod 10 mg per kg per dose was administered as a weekly infusion for 4 weeks, and the cycle was repeated after variable intervals of 8 weeks or more, depending on the reemergence of symptoms and tolerability. The total follow-up period was 26 weeks. Among the 167 patients, 84 in efgartigimod and 83 placebo enrolled. 77% had acetylcholine receptor positive. Compared with the placebo, the efgartigimod treated acetylcholine receptor myasthenia gravis had significant improvement in the MG-ADL score at 4 weeks. The other efficacy scores, the QMG, the MGC, and the MG quality of life 15 revive, showed a similar pattern with maximum improvement noted by 4 to 5 weeks, which was sustained for 7 weeks. The drug was well tolerated, and adverse effects, including the serious one, were no more than in the placebo group. Headache was a common reported symptom, which was similar in both the groups, whereas mild to moderate infections were more common in intervention group when compared to the placebo. The efgartigimod produced 60 to 70% reduction in the levels of total IgG and all IgG subtypes commencing in the first week of the initial dose, and the levels inversely corresponded with the clinical improvement. The levels of anti-acetylcholine receptor antibody also fell by 40 to 70% in most of the patients, with recovery by 12 weeks after the first infusion. The resurgence in antibody and IgG levels occurred prior to or parallel to symptomatic worsening. The other therapies which have been tried are the cytokine and chemokine targeting therapies. The targeting of cytokines can impact either or both of the B and T cell mediated mechanisms of pathogenesis. The viable targets include the CD40 CD154 pathway, which is important for the activation of B cells and the differentiation of plasma cells through the other immune cells. The B cell activating factor pathway, which plays a key role in B cell maturation and survival. The chemokines, the CXCL13 signaling, and its receptor CXCR5 expressed on the B cells and T follicular helper cells play a major role in the migration of B cells to the secondary lymphoid organs and for the development of germinal centers. The interleukin 17 pathway is a cytokine secreted by the pro-inflammatory Th17 cells and which is overexpressed in myasthenia gravis. The interferon 1 pathway, which is overactivated in thymus-associated myasthenia gravis and early onset myasthenia. The IL-6 pathway IL-6 is a pro-inflammatory has a pro-inflammatory activity influencing both the B and T cells, and it induces the conversion of the T helper to Th17 pro-inflammatory cells and promoting the maturation and survival of the plasma cells. So the IL-6 is a soluble cytokine which mediates a variety of functions, including inflammation, immune responses, and the hematological functions. In the acute phase of inflammation, IL-6 facilitates the production of subgroup of acute phase reactants and augments the immune function by stimulating hematopoiesis. However, it plays a major role in the transition of acute neutrophilic inflammation to chronic mononuclear infiltrates, paving the way for the potentially harmful chronic inflammatory response. Its role in acetylcholine receptor myasthenia gravis was illustrated by the presence of elevated IL-6 in treatment-naive patients and subsequent suppression of levels with immunotherapy. Antibodies against IL-6 could downgrade the pro-inflammatory Th17 response and suppress the symptoms in experimental autoimmune MG models. So tocilizumab and satralizumab are the monoclonal antibodies against the IL-6 receptors, which have been approved for other chronic autoimmune diseases. However, still trials are undergoing for approval in myasthenia gravis. Subcutaneously administered satralizumab has been effective in reducing relapses in anemospectrum disorder, both as monotherapy and add-on immunotherapy. Johnson et al. Described 2 patients with refractory myasthenia gravis who responded to intravenous tocilizumab after the failure of classical immunotherapy, thymectomy and repeated doses of IVIG and rituximab. Both drugs are under development as therapy for generalized myasthenia gravis. Rituximab, rituximab is a chimeric human mouse anti-CD20 monoclonal antibody and has gained a wide acceptance as a therapy for severe and refractory myasthenia gravis. Rituximab rapidly depletes the memory and mature B cells in the peripheral blood while largely sparing the pre-B cells and the plasma cells located in the bone marrow and secondary lymphoid organs. This depletion is achieved by antibody-dependent cell-mediated cytotoxicity, complement-dependent cytotoxicity, and apoptosis of the target cells. The effect persists for about 6 months before the circulating B cells are repopulated in the bone marrow. So the pathogenic antibodies in myasthenia are produced by the plasma cells which reside in the bone marrow. Rituximab spares the long-lived plasma cells which do not express CD20, while it diminishes the short-lived plasma cells and the B regulatory cells which have the CD20 expression. In general, the suppression of antibody production is transient in myasthenia. As anti-acetylcholine receptor antibodies are produced by long-lived plasma cells, whereas the MuSK antibodies are thought to be secreted by the short-living plasma cells. Theoretically, it suggests that the MuSK myasthenic gravis have more responsive to the rituximab therapy. So, coming to the trials which have been reported in myasthenia gravis, there have been multiple systemic reviews and meta-analysis of patients which have shown a marked clinical improvement in patients who have been treated with rituximab. These are some of the trials which have been mentioned. Coming to the other B cell mediated therapy, which is the inebilizumab, which is a humanized monoclonal antibody against CD19 expression in the B cell lineages. So the CD19 markers cover a broader group of cells apart from the CD20. The CD20 is restricted to the pre-B cells in the bone marrow and the circulating naive, mature, and memory B cells, whereas the CD19 is additionally expressed on the early pro-B cells and the majority of the plasma cells in the blood, secondary lymphoid organs, and about half of the plasma cells in the bone marrow. The predominant mechanism of B cell depletion in this is the antibody-dependent cell-mediated cytotoxicity. It has been approved for treatment for NMOSD in June 2020 and is under evaluation for other diseases like IgG4. Inebilizumab is currently undergoing the phase 3 clinical studies for myasthenia gravis patients. The main study is the randomized placebo-controlled trial of intravenous inebilizumab in an antibody positive generalized myasthenia gravis as an add-on therapy. So the currently approved drugs of the complement inhibitors include the eculizumab, the ravulizumab, which have been approved for acetylcholine receptor positive generalized myasthenia gravis. The zilucoplan has been approved recently in 2023 for again generalized myasthenia acetylcholine receptor positive antibodies, and the rest of them are still under phase 3 studies. The FcRn blockers, which include the F-gantry-Gmod, has been approved for the acetylcholine receptor positive generalized myasthenia gravis. The rozanolixizumab is still under the phase 3 study, and it is still completed, and the approval is still pending. The other B cell targeted therapies, rituximab, the data on multiple studies have shown a good benefit, and inebilizumab is still under the phase 3 study. The other B cell and plasma cell targeting therapies like bortezomib and tolebrutinib are still under phase 2 and phase 3 studies. The chemokine, the pathways targeting the chemokine and cytokine pathway are again still under trials. And the IL-6 receptor antibody, the tocilizumab and the citralizumab, are under phase 2 and phase 3 studies. So the other therapies, including the hematopoietic stem cell therapy and the CAR T cell therapy, are also under phase 1 and phase 2 trial and still require further studies to come as the still long wait for the approval. So that is my topic on novel immunotherapies in myasthenia gravis. Thank you.